Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 501 of our pharmacotherapy series, which majors in anemias. The first case reads, TCL is a 63-year-old Scandinavian man that is seen by a private physician. TCL has a 1-year history of weakness and emotional instability. He also complains of a painful tongue, alternating constipation and diarrhea, and a tingling sensation in both feet. Pertinent findings on physical examination include pallor, red tongue, vibratory sensory loss in the lower extremities, disorientation, muscle weakness, and ataxia. Significant laboratory findings include the following: a hemoglobin of 8.7 grams per deciliter, a hematocrit of 27%, an MCV of 115 femtoliters, an MCH of 38 picograms per cell, an MCHC of 340 grams per liter, reticulocytes of 0.4%. Poikilocytosis and anisocytosis on the blood smear. White blood cell, WBC, count of 4,000 per microliter. Platelets of 100,000 per microliter. Serum iron of 90 micrograms per deciliter. Total iron binding capacity of 350 grams per deciliter. Ferritin of 140 nanograms per milliliter. RBC folate of 300 nanograms per milliliter. Serum vitamin B12 of 90 picograms per milliliter. Intrinsic factor antibody is positive. So my first question to you reads: what signs, symptoms, and laboratory findings in TCL are typical of pernicious anemia? TCL's signs and symptoms are classic for pernicious anemia. This disease occurs equally in both sexes, primarily in individuals of Northern European descent, with an average onset of 60 years. Pernicious anemia develops from a lack of gastric intrinsic factor production, which causes vitamin B12 malabsorption and, ultimately, vitamin B12 deficiency. TCL's signs and symptoms of vitamin B12 deficiency include painful red tongue, loss of lower extremity vibratory sense, vertigo, and emotional instability. The elevated MCV suggests megaloblastic anemia. Folate and iron are two other factors that can affect the MCV and should be evaluated during the workup of a patient for anemia. In this case, TCL's folate and iron levels are normal, but his serum vitamin B12 level is low. The presence of poikilocytosis and anisocytosis observed in the blood smear represents ineffective erythropoiesis. Other cell lineages also may be affected in the bone marrow. Erythroid hypercellularity, along with a decrease in the myeloid cells, leukocytes and platelets, increases the erythroid to myeloid ratio in TCL. The patient's low hemoglobin, elevated MCV, low serum vitamin B12 levels, and presence of intrinsic factor antibodies are compatible with the diagnosis of pernicious anemia, which is often associated with atrophic body gastritis. The Schilling test, which confirms intestinal malabsorption of vitamin B12, is no longer available in the United States. My second question to you reads: how should TCL's pernicious anemia be treated? How soon can a response be expected? TCL should receive parenteral vitamin B12 in a dose sufficient to provide the daily requirement of approximately 2 mcg and the amount needed to replenish tissue stores, about 2,000 to 5,000 micrograms, average 4,000 micrograms. To replete vitamin B12 stores, cyanocobalamin can be given intramuscularly. Intramuscular or deep subcutaneous administration provides sustained release of vitamin B12 with better utilization compared with rapid IV infusion. An oral tablet or intranasal cyanocobalamin solution is also available for maintenance therapy, after the patient has normalized blood counts. Treatment with vitamin B12 should completely reverse the hematologic complications of pernicious anemia. The reticulocyte count increases within the first week of treatment and the megaloblastic anemia resolves within 6 to 8 weeks. Neurologic symptoms may worsen at first and then resolve over weeks to months. Some symptoms may never resolve completely. Because the rapid production of RBCs can increase potassium demand, serum potassium should be monitored and potassium supplementation provided as necessary. Peripheral blood counts should be obtained every 3 to 6 months to evaluate the adequacy of therapy. If maintenance therapy is discontinued, pernicious anemia will recur within years, making patient adherence vital to long-term success. My final question to you reads: what factors affect the oral absorption of vitamin B12? When might oral vitamin B12 therapy be an effective alternative to parenteral therapy for TCL? The amount of vitamin B12 that can be absorbed orally from a single dose or meal ranges from 1 to 5 mcg. Approximately 5 micrograms of vitamin B12 is absorbed daily from the average American diet. The percentage of vitamin B12 absorbed decreases with increasing doses, 50% of a 1 microgram dose and 5% of a 20 microgram dose. Overall, oral vitamin B12 therapy is considered safe and effective, although because of lack of long-term efficacy data, oral supplementation is not routinely used in the acute treatment of vitamin B12 deficiency. Oral therapy for pernicious anemia using high dosages of oral cyanocobalamin may be indicated in certain patients, especially those who refuse or cannot receive parenteral therapy. Issues of non-adherence or lack of response with oral therapy places the patient at substantial risk for significant neurologic damage. Patients receiving oral vitamin B12 therapy should be monitored more frequently to ensure adherence to therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 502.